Hello to everybody. Can I have my slides, please, for introduction? For me, it's a very special occasion to have the privilege to introduce Will Chapman, our Congress chairman. Will is professor of surgery, Eugen Bricker Chair of Surgery, Chief Division of General Surgery, and Chief Abdominal Transplantation Section in Washington University of St. Louis. He was president of the HPBA, president of the Western Surgical Association, president-elect of the ATS at the present time, and director of the American Board of Surgery. During his presidency in the HPBA, over several achievements, Will supported and promoted the creation, organization, and development of different chapters, so important now to our organization. And you see him in a transplant meeting in Latin America and giving the award to Carlos Chan, president of Mexican chapter. Will is an extraordinary mentor and leader. And you can see here a picture of his team from the last Christmas party. Magella Doy over there, our AHPBA president now. But knowing Will for so many years, I can say that the most important thing for him is family. The wonderful family Marty and Will have developed. With you, ladies and gentlemen, Will Chapman.
Thank you, Javier, for that very kind and generous introduction. It's been great working with you over so many years, and I cannot compliment you enough on the meeting and the work you put in to make this meeting happen. The AHPBA and the IHPBA are the most unique and respected associations in the field of HPB surgery. And being selected as the local head of the local organization for this international meeting, only the second in North America, the last being in 2004, is a real honor and a humbling event. Thank you all for this incredible privilege. Now, this meeting has been packed with activity, and while I know it's been overwhelming in many respects, I hope you all have had a chance to take advantage of the scientific activities, but perhaps the best part of this meeting has been having the opportunity, once again, to meet face-to-face, reconnect with past friends and colleagues, and make new friends. Before I begin, I'd like to especially thank Jill and Margie and their team, who really did the majority of the work at the ground level to make this meeting a success. So join me in giving them a hand. Before I begin, I'd like to disclose one conflict I have. I'm on the board of directors of the local OPO for St. Louis, and I'm going to talk about that some in this meeting. Now, what I'd like to do in the next few minutes, besides recognizing a few individuals who've been personally and professionally critical to me in my career, is discuss some of the unique events that have occurred since our last meeting 2 years ago. In addition to the worldwide pandemic, we've lived through increased recognition of some long-standing and serious social and healthcare disparities, both in the United States and worldwide. The main theme for this talk is really focused on transplant oncology, which I think is an area that provides great opportunity for all of us involved in HPB and transplant surgery, especially for our patients. Finally, I'd like to touch on some of the new technologies and innovations in the field of transplantation that I believe will allow us to utilize more deceased donors and help more patients, especially those with hepatic malignancy. We live in St. Louis, Missouri, as you heard earlier, probably best known for the arch that was constructed in 1967 after a competition to establish a landmark representation of the city. St. Louis has always been known as the gateway to the West and the land of opportunity. St. Louis is a river city built in early development of the United States based on river traffic. Probably the best known St. Louisan is Charles Lindbergh, shown here with his plane, the Spirit of St. Louis, the first manned aircraft to complete a transatlantic flight, which occurred in 1927. What many don't know is Charles Lindbergh was also instrumental in development of organ perfusion system. He's shown here with Nobel laureate Alexis Carrel after designing the first successful organ perfusion system, which, by the way, it seems we've come full circle as we're now using more perfected but similar oxygenated perfusion systems in organ transplantation. Now, Charles Lindbergh was featured on the cover of Time magazine on 3 occasions. Most would say, one time you've made your career. He was featured 3 times, but later fell into disfavor after being seen to support efforts of the Nazi regime during World War II. Now, I was planning to go to Bern, Switzerland to work with Professor Les Blumgart in 1990. 3 months before I was to go, he announced his plans to move to New York. So subsequently, I spent a year in London with his previous team there. Professor Blumgart is shown here with Bill Jarnigan, the first fellow at Memorial and one of their trainees. I had the opportunity to visit with Sarah and Les Blumgart yesterday. He really regrets not being able to be at the meeting, but his mobility is so limited that he was just not able to come. But he did ask me to pass along his regards to all here. My training at King's in 1990 was intended to be solely focused on HPB surgery. However, the King's unit performs the largest number of liver transplants in Europe. So at the advice of Jerry McEntee, HPB and transplant surgeon from Ireland, who was there at the same time, I spent some time working with the transplant team. I returned to Vanderbilt as an HPB surgeon, but after 2 years there, one of the other transplant surgeons had left, and Wright Pinson, the transplant chief, asked if I would join he and Kelly Wright in what turned out to be on-the-job training. Tim Eberline and Greg Sicard recruited me to come to WashU in 2002. And they were really instrumental in allowing our transplant program to move forward. And I owe both of them a great debt of gratitude. Now, you heard earlier about our transplant team. We've, over the years, have been able to convince a number of great surgeons to join our team. Shown here, Majella Doyle, well known to this group, and Adil Khan. What we've also had the great fortune of is working with an outstanding HPB team, currently led by Bill Hawkins. I've included David Linehan With this group, David was the prior head of the group, and Jeff Drebin was with us also. But we've been able to have a very, I would say, cohesive group, which has really been beneficial to the work that we do. COVID has clearly been a major overarching event of the last 2 years. And I would just like to remind everyone of what a nightmare we've lived through. The first cases of COVID were recognized 2 years ago, but it was really right after the AHPBA meeting, the last in-person meeting in March of 2020, that everything shut down in the US and worldwide. We faced dire circumstances with furloughed and fired staff, medical centers that were worried about impending closure, 401 reductions, and other disasters. Miraculously, we've been able to recover from those circumstances, and especially emotionally. There have now been almost 500 million confirmed cases of COVID worldwide and over 6 million deaths, something never seen in the course of our lifetime and not seen since the worldwide pandemic of 2018. There are many aspects about this situation that I could talk about, but I'm not going to discuss those today. What I would like to mention is the HPB group in Wuhan, China. Now, I think many in this room have had personal experience visiting Wuhan. Wuhan is I think it's the 5th largest city in China. It's very sophisticated. It's bigger than New York, over 12 million people. Wuhan is a river city in the center of the country, and as some would say, is a sister city to St. Louis. Xiaoping Chen has been a major leader in Wuhan and has had many of us there for his international HPB meetings. Professor Chen could not join the meeting here this year because of travel restrictions, but he did pass along his regards. And by the way, he was elected to fellowship of the IHPBA at this meeting, another honor to his credit. Now, the leadership of the IHPBA and the AHPBA have really done an outstanding job navigating the circumstances of the last 2 years and bringing this meeting to fruition. As you can imagine, this has been an on-again, off-again experience over the last 2 years, including only about 2 months ago when national meetings in the US were all being canceled. So I'd really give great credit to Nora Hero and Mike D'Angelico for their leadership and other members of the team. I'd also like to recognize the local organizing committee who I think has done a great job organizing events of this meeting, especially Magella Doyle and Kareem Halasan. So let's talk for a few minutes about transplantation for hepatic malignancy. Now, liver transplantation was originally conceived as ideal therapy for hepatic malignancy because it allows for the removal of advanced tumors as well as potential sites of recurrence. I'd point out it's the only solid organ where transplantation is considered as appropriate in the setting of malignancy. Now, having said that, the early case results were really dismal, and this was considered a contraindication to transplantation. Today, we consider transplantation for HCC, cholangiocarcinoma, metastatic neuroendocrine tumor, and metastatic colorectal cancer. And I'm going to touch on these all briefly. This is a report from Tom Starzl and the Pittsburgh group in 1985, where they transplanted a variety of tumor types. And what I'd point out is these patients had a 74% one-year recurrence after transplantation. And after this, no more transplantation for any malignancy at almost every center in the U.S. until the landmark paper by Mazzaferra and the Milan group showing excellent results for liver transplantation in early stage HCC. And this changed the paradigm across the world. Patients with more advanced stage HCC did not fare as well. And I would just mention this, there were 13 patients out of 48, a very small number, that did not have the same favorable results, who had more advanced, slightly more advanced HCC, not pretreated. And this was the basis, I think, for essentially not considering patients with more advanced stage disease. So this led to the staging system used by the American Liver Tumor Study Group, and I would say most places in the world, where the only patients who receive consideration for transplant are those with T2 tumors, really a small volume disease. And this has been a limitation in many parts of the world for patients with slightly more tumor status. This is a graph of a paper just published in the last week that Ola Ahmed and Majella Doyle spearheaded. It's a multi-center study, almost 1,000 patients, including those with beyond UCSF, HCC before downstaging, compared with those within UCSF. And what this shows is that the outcome results are excellent when patients are carefully selected, including those who are beyond UCSF before downstaging. It's not so much where you start, but it's where you end up after treatment and observation. These are data from WashU of our transplant experience since 2000. And I just show this to give you a snapshot of where we've been. We've had 500 patients with diagnosed HCC before transplant. We've pretreated 460 of those, and 100 were beyond Milan and downstaged. And this includes 21 patients with stage 4A and 10 patients with tumor thrombus that most would consider will never be a transplant candidate. These are the results. I would say excellent outcomes with 10% recurrence in the within Milan group, and those beyond Milan have a slightly higher but not statistically different, small number of cases, outcomes in those including with tumor thrombus. Well, what about hilar cholangiocarcinoma? The Mayo Clinic group has really led the efforts nationally. I want to highlight one publication from that group showing how beneficial this can be. This is a multi-center study from 12 sites with 280 patients. Starting off, 71 dropped out, 214 transplanted with hilar cholangiocarcinoma. Recurrence rate of 40%, but with excellent outcomes for those who underwent transplantation. Now, those with PSC fared more favorably, but even patients with de novo cholangiocarcinoma had excellent outcomes. What about intrahepatic cholangiocarcinoma? This is a a graph from Gonzalo Sepichin's paper. We've heard about this at this meeting, demonstrating that patients with intrahepatic cholangiocarcinoma, previously thought to be a strong contraindication to transplantation, can have excellent results also, especially those with small tumors in the setting of cirrhosis. What about metastatic neuroendocrine tumor? The French group have done an excellent job bringing this to our attention. This is a report from 2013 from the European Liver Tumor Registry, showing that carefully selected patients with favorable factors can have excellent long-term outcomes with metastatic neuroendocrine tumor. And this has led to selection criteria that I think many or most centers now would consider in patients with metastatic neuroendocrine tumor, and especially to avoid those with unfavorable factors. At this meeting, Paul Dacklein has presented the Norway group's experience transplanting patients with metastatic colorectal cancer. And they've demonstrated excellent overall survival at 5 years with patients who are carefully selected. Again, small series. This has to be looked at carefully on a more expanded basis, but this is an indication that only a few years ago we would have never considered for transplantation. And they have recommended inclusion and exclusion criteria. It was great having them here. There was a lot of discussion about this topic. The IHPBA assembled a group that put together consensus recommendations on transplantation, and I think this is something that we will all be looking at carefully in the future. Okay, well, when you suggest expanding transplantation for patients with malignancy, immediately there's a lot of concern about trying to bring up new indications for transplantation. Well, why is that? Because we have a severe organ shortage in the United States. This shows our annual number of transplants. This is in the U.S. 25,000 patients are candidates over the course of a year. So, you know, to say, okay, let's do more transplants, how are we going to get that accomplished? There are several aspects that I would mention that I think we do have opportunities for, and we can expand transplantation, I believe, significantly. These are data from the OPTN looking at organ utilization for liver transplantation. And what you can see across the various regions of the United States, even after introduction of broad allocation, we only utilize about 67% of livers recovered for transplantation. This doesn't even include the organs that aren't even recovered. We leave a lot of potential organs out of the picture that we could utilize. So how might we do that? I want to mention two strategies. One is establishment of donor recovery centers, and two are new strategies for organ preservation. We live in St. Louis, as I've told you. This is our local OPO. It covers about almost 5 million people, 100 hospitals, 4 transplant centers. In the past, before 2001, if we had a organ donor in our area, all the team flew out, just like what occurs around most of the country. In 2001, our OPO, in conjunction with WashU, started a new concept, and that was, let's set up a recovery center and move the donor to the recovery center in St. Louis, where the transplant programs are established. Since that time, over 2,000 donors have been moved and recovered in the center. These are photos of the recovery center. It's like a mini hospital. There's a 6-bed ICU. There's an excellent operating room. There's a CT scanner. The OPO has a plane to transport the donors. And this is the building where this is housed. Importantly, there are many aspects that make this a positive experience, but I'll mention a couple. One, donor costs, 50% less recovering a donor. 50% of the expense, which is a dramatic reduction. I would also point out we've had this leads to an increase, I don't have it here, but increased organ yield because the donor center, the concentration of the donor center, unlike an acute care hospital, is maximizing organ recovery. So significantly increased donor recovery. This shows now 11 sites across the United States that have been established as freestanding organ recovery centers. This is the way of the future. Finally, what about organ preservation and perfusion systems? There are currently 3 hypothermic perfusion systems and 3 normothermic perfusion systems in various stages of development. These have been shown to improve organ performance in marginal organs. This is a picture of a system developed by the Zurich group, Pierre Clavien and his team, that has the potential to maintain livers for up to 7 days for rebuilding, rescaffolding. Where these are all going to fit in and play out, I don't think we know, but I think it's coming in the future. Now, I would mention we started a FDA IDE approved protocol a year ago to look at organs that were deemed to be discarded and use machine perfusion to assess the organs. So we have recruited 15 livers as part of that trial. 11 of those passed viability criteria and were transplanted. We had 2 of those 11 patients died of non-transplant related causes. The other 9 have fared well. So this is a strategy that I think is going to allow us to assess many of those organs that we currently are discarding. I think there's a lot of opportunity to expand transplantation and benefit many patients that we currently are not offering or considering for transplant. In closing, I cannot thank my wife Marty and our kids for the support they've given to me over the course of my career. So, thank you all for being here this week. It's been a great meeting, and it's been great to have you here. Thank you.